Welcome, everyone, to the American Academy of Developmental Medicine and Dentistry's virtual Grand Round. Our VGR tonight is an exciting array of folks from Special Olympics. I'm so proud and happy to have them here with us tonight. AADMD has three facets. One is advocacy, the other is education, and thirdly, access to care for people with IDD. And we've been an organization that is struggling and trying to help people without a voice to have a voice. And tonight we have a great cast of panelists, and I'm going to let our VGR facilitator, Cindy Lee from Penn Dental, introduce our staff, our panelists tonight. Cindy?
Thank you, Dr. Wong. Hi, everyone. Welcome to our October virtual Grand Rounds. My name is Cindy Lee, and I'm a fourth-year dental student at University of Pennsylvania School of Dental Medicine in Philadelphia, and this year's American Academy Developmental Medicine and Dentistry Virtual Grand Rounds facilitator. For those that are new, virtual Grand Rounds are a 7-webinar-based presentation model that creates a space for mentorship and exchange of knowledge and experience between seasoned IDD providers, entry-level clinicians, and future healthcare providers in training. The purpose of this Grand Round session is to expand and strengthen the IDD healthcare workforce across a spectrum of experience levels. So thank you guys all for joining today. If you guys have any questions throughout the presentation tonight, you may write your questions in the Q&A box on the sidebar. Any unanswered questions will be discussed at the end of our presentations, so please make sure to send questions in the Q&A box and not the chat box. Now, I would like to introduce our VGR presentation and our speakers for tonight. We'll be discussing how to support healthy relationships and sexual health for people with IDD. First, we have Dr. Alicia Bazzano. As Chief Healthcare Officer of Special Olympics, Dr. Alicia Bazzano provides strategic oversight of health activities around the world to ensure public funding, policies, medical training programs, and healthcare service delivery that are inclusive of people with intellectual disabilities. Dr. Bazzano completed medical school and pediatric residency at UCLA. She also completed her master's degree in public health and her doctoral degree in the Department of Healthcare Policy and Management at UCLA. She's a pediatrician and public health executive who has dedicated her career to improving the health of people with intellectual disabilities. Second, we have Dr. Iulia Mihaila obtained her PhD in human ecology with an emphasis in human development and family studies from the University of Wisconsin. She recently completed postdoctoral training as a leadership education in neurodevelopmental and related disabilities fellow at the University of Illinois at Chicago. As a senior manager of research and evaluation at Special Olympics, her research interests lie in health promotion for individuals with intellectual and developmental disabilities and their families. And lastly, we have Savanah Overturf. She's a Special Olympics health messenger from Fort Collins, Colorado. Being part of the IDD community herself, she's been a Special Olympics athlete for 10 years. Savanah provides leadership to develop and pilot the training on healthy relationships for Special Olympics. And she believes that there are no disabilities, only unique abilities. And that being said, please welcome our VGR presenters for tonight. And I'm going to turn it over to Dr. Bazzano.
Thank you so much, Cindy. And thank you, Alan, as well. Appreciate the opportunity to get to speak about such an important topic, supporting healthy relationships and sexual health for people with intellectual and developmental disabilities. This is a topic that we've been talking about and working towards improvements in for quite a long time, and very excited to be able to share with you some of the work that we've done, as well as hopefully some information that you will be able to take going forward into your practices. So we're going to start off with some background information and discuss the statistics and epidemiology of sexual violence we're going to talk about trauma-informed care. We're then going to discuss how to advocate and how how self-advocates can contribute to their own health, and in that we're going to discuss our Special Olympics Healthy Relationships pilot, and then we'll finish up with questions as well as a call to action for all of you out there. So we can, if I can start, I'm going to share a story about one of my patients, and I'll call him Troy. This is a young man who had intellectual disability and autism, and he did not communicate verbally except in short phrases. He was 14, and he actually came into my clinic due to a urinary tract infection. So he was now in 9th grade. He had gone from his middle school to his high school, and his family was actually bringing him in because he was having difficulty with that transition. So he had been much more aggressive. He was refusing to go to the bathroom, and eventually ended up urinating in his seat. He was having a lot of difficulty with this new school environment as well, in general, and he just wasn't thriving or getting along well. So we did a urine. We took a urine sample, which was a bit difficult with him, and we found that he had an E. coli in his urine, very typical for a UTI. And urinary tract infections are all often associated with some fecal contamination. So we used a typical antibiotic for that. And to help him with his transition to the new school, we had him see our mental health professionals and our psychiatrists. So he had already been on an antipsychotic, and we increased the dose, that the psychiatrist increased the dose of his antipsychotic medication. So we had addressed his concerns, the family's concerns, as much as we could. And it wasn't until about 2.5, 3 months later that he came back. So when he came back, he actually was doing much worse. So he was continued to have pretty significant aggressive outbursts. He was at this point using diapers, not going to the bathroom at the school at all, really having a lot of incontinence issues. He had regressed in his verbal abilities, and it didn't seem like the antipsychotic was helping very much at all. We continued to be concerned, although he had never had any history of any congenital abnormalities or structural abnormalities with his kidneys or his urinary tract at all. But upon getting a second urine, he actually had indications of a second UTI. So I'll fast forward, and when we got the results back, they were pretty stunning. He actually had a chlamydia UTI. And the moment we got that back, we recognized, I recognized that this was a much larger situation, and the likelihood that this was a situation of sexual assault, sexual abuse of a young guy, and that we had missed it potentially for what could have been about 4-month period. I share this with you in the hopes that as we're going through and as we're thinking about this, you can learn from this just like our team did. And if we can prevent situations like this, we, I think, can do a lot of good just by recognizing that sexual assault and sexual abuse are serious issues for people with intellectual and developmental disabilities. So it's with that I'll share with you a couple of the lessons that I want that we'll be going through for you all to think about. First of all, we all talk about behavior, and we often talk about behavior in the context of not regulating your own emotions, having difficulties with self-regulation, awareness. But behavior is, of course, communicating. And in this case, Troy's behavior was looked like acting out, but it was really communicating his trauma that we were missing. What I also want to point out is that although we don't typically think of diagnostic overshadowing in this kind of setting, what we were doing was saying to ourselves, well, gee, he's got intellectual disability, he's got autism. Maybe this UTI in the first place was caused because of not wiping himself, or his caregiver assisting in him not getting some kind of fecal contamination there. Maybe it was caused by some kind of behavior that was related to the intellectual or developmental disability. Whereas if this were a young man at 14 who didn't have an intellectual disability, I don't think we would necessarily be thinking that, and we shouldn't, because UTI is very rare in 14-year-olds, and that's across the board. So what we were doing was thinking about this condition as due to the intellectual disability diagnosis, and that's called diagnostic overshadowing. You overshadow the other diagnosis and blame it all on the intellectual disability. The other aspect to this that I just want to point out, and we'll point out again as we go through, is that we aren't alone in when we're in this kind of situation. And a big part of that is because, I don't know about you all, but I can tell you from my perspective, I never got training on sexual assault, sexual abuse, and intellectual disabilities. Never. It never crossed anyone's, it wasn't on any, it's not even in any journal articles. Inclusive sexual health isn't even a phrase that you can Google. It's really not on people's radars very, very much. So how does this come to happen? Next slide. When sexual violence is ubiquitous, when we're in the midst of the Me Too movement, and when, for people with intellectual and developmental disabilities, this is a much worse situation even than the general population. So ubiquitous that 83% of women, more than 4 out of 5 women with developmental disabilities, have been victims of sexual assault at some point in their lives. And 32% of men with intellectual or developmental disabilities, again, have been victims of sexual assault. That's tremendous. That means that almost all of your patients who you see have been affected by sexual violence. Half of people with intellectual and developmental disabilities who are victims of sexual assault will experience 10 or more abusive incidences. So that just means over and over again. And then 7 times, so people with intellectual and developmental disabilities are sexually assaulted at a rate 7 times higher than those without disabilities. We talk about sexual violence, and I just want to point out sexual violence is the term overall. Sexual assault is a term that is specific. Sexual abuse is a particular type of abuse that occurs in childhood, similar physical abuse or neglect also. It can certainly happen to adults. And then sexual assault has different different conditions, and when we are specific to penetration, then that is typically termed rape. Want to make sure you're aware of some of those terms there. If we can go to the next slide. So why is this happening so much for people with intellectual and developmental disabilities? Well, first of all, we know that part of intellectual disability is a challenge with communication. Part of the definitions of both intellectual disability and autism include those. These communication challenges, especially when they occur with expressive language, make it more difficult for people in this situation to report or to stop abuse, because it's more difficult to communicate in those traditional ways. And similarly, the isolation that people with intellectual and developmental disabilities face also contributes. So there's a limited opportunity to be in a relationship, in a normal, typical romantic relationship, and to understand what is a typical friendship, what typical boundaries are. So many learn information not in any kind of formalized settings. They don't have very many opportunities to practice the skills that they might learn either. And in general, there are limited opportunities for typical socialization. Next, in general, our society has a lot of myths and misconceptions about people with intellectual and developmental disabilities. Very commonly, it's that people with IDD are not sexual, that they don't engage into any sexual activity, that they're not going to get married, that they're not going to engage in sexual intercourse, and that they simply don't have those feelings. And that's a complete misconception. It's completely erroneous. And when we have that attitude, we don't address the issue. We don't recognize these issues can come up. And we don't give the education and the prevention that we need. And then that plays into this lack of sexual education. So a number of studies have found that people with intellectual and developmental disabilities have less information. They are less often included in sexuality education than the general population. So all of these root causes really are not inherent to intellectual and developmental disabilities. They're systemic. And they aren't even inherent to people with intellectual and developmental disabilities, but they are really rooted in our society's perceptions and treatment of people with IDD. So what does that mean? Next slide, please. That means that these are causes that can be addressed. These are things that we can change. This really means that sexual violence, including sexual violence in people with intellectual and developmental disabilities, is preventable. These occurrences of violence have enormous physical, mental, and social ramifications. And the repercussions of sexual abuse are more prominent in people with disabilities. There is a greater need for education and a greater need for care due to these vulnerabilities, due to the complex health needs, and due to this lack of accessible and inclusive education and resources. But by equipping people with intellectual and disabilities with education, by equipping their caregivers and their healthcare providers with the tools that they need to advocate, on the one hand, for people with IDD to be able to advocate, to develop their own healthy relationships and to advocate for their own health needs. And on the other hand, for caregivers and health professionals to recognize those needs and to develop systems for better patient care, then the overall healthcare system can be strengthened, and all of these cycles of violence can really be brought to an end. So how can we, as healthcare professionals, help? What can we do? First of all, we can recognize what this is. This sexual violence is trauma, and we need to address it as though it's trauma. And that means that every single patient who comes into your office, this needs to be recognized and treated like trauma. So trauma-informed care is the way that we treat trauma, and that means that we are understanding and taking into consideration the pervasive nature of trauma, and we assume that it is more likely than not that our patient has a history of trauma. And that prompts us to recognize trauma symptoms and to acknowledge the role that trauma can play in a patient's life, and that we have the opportunity and the requirement to promote an environment of healing and recovery, rather than practices and services that can actually re-traumatize. Now, of course, we don't intend to re-traumatize. This is unintentional. But we do have significant portions of our healthcare system and our unconscious biases in relationships that can promote re-traumatization, which is not what we want to do. So in order to recognize that, at the system level, here are a few things that can re-traumatize. First of all, having to constantly retell the story. Every retelling is pain. And we're asking each of those individual patients to go through that pain again. So as much of avoiding the retelling through continuity of care, through interdisciplinary care, group care, rather than individualizing it, individually telling each different healthcare provider, that can help. Being treated as a number. So instead of developing that individual relationship, having our healthcare system typically promotes treating everybody pretty much the same, and we don't want to do that. We want to individualize the care. It has to be evidence-based, but it also has to be individualized. Recognizing that every time we ask a patient to get into a gown, we're asking them to take their clothes off, to be naked, to disrobe, and that's uncomfortable. It's uncomfortable in general, but it is much worse when you've been traumatized in this way. We also, I know that we all use language that is people first, but not everybody does. We really need to be aware of that and recognize people don't want to be called disabled people. I certainly don't want to be called anything else other than people with intellectual disabilities in terms of some of those old phrases we used. The other systemic issue is that there's very little choice in how we receive services and how we receive treatment. And there's really not an opportunity for a back and forth dialogue on this. On the individual level, when we talk about re-traumatizing, what we talk about is taking away power, control, and creating a sense of submission and being subversiveness. So in this sense, it's a not listening to the patient so that the person doesn't feel seen or heard. It's violating trust instead of building trust. It's failing to provide a sense of emotional safety. Is this a safe place, or am I being told how to think or act or feel? It's a non-collaborative top-down environment. Is this a hierarchy, or are we partners? Every time we stand on top of a patient instead of sit with them, every time we wear our white coats instead of be at the same level, every time we use jargon instead of use plain language, we're not being collaborative. We're not allowing for safety. We're not creating trust. Every time we do things for someone rather than with someone, assume that someone needs help rather than ask. That's all taking away the power and control. And in a person with an intellectual disability who's been traumatized, this is really re-traumatization. And then finally, we hope that we don't do this, but certainly there are incidences in the use of punitive treatment and coercive practices, pushing someone to do something. In this case, it was very difficult to get Troy to be able to participate in his urine collection sample. Could we have done better with allowing him for more choice and control in this? Yes, I believe we could have. Oppressive language. So I mentioned people first language. I mentioned using plain language. When we don't do those, it can be very oppressive. When we talk about shoulds and you must and you need to and all of those as well, those are language that can be very, very triggering. So what we want to get to is some themes that are important in care for people who have trauma in general, and then specifically with people with intellectual disabilities and developmental disabilities. So here we go through trauma-informed care principles, and they're kind of like the opposite of the re-traumatization. So here we do create an environment of safety, both physical and emotional safety. The common areas we're looking at are welcoming, and we respect privacy. We don't talk in the hallways. We don't try to make decisions in the absence of the person with intellectual disabilities. We give choice. That's through providing clear and appropriate messages about patients' rights. You have the right to be informed. You have the right to participate in your treatment. You have a right to not have treatment. You have a right to be educated, and you have these responsibilities as well. Collaboration, making decisions with the individual and sharing the power. This is very difficult in when there are family dynamics, when there's caregivers who are well-meaning, and when we are as well, for us sometimes to turn off that caregiving and be partners instead. Individuals should be provided a significant role in their own planning and the evaluation of the services that they need, even when they don't communicate verbally. Trustworthiness. So here, this is about integrity. This is about saying what you're going to do and then doing that and not doing anything else. That's when we build trust. With clarity, with consistency, with transparency, and with boundaries. So we all hear about boundaries. There are physical boundaries. There are boundaries that we shouldn't cross in discussions. And by being respectful of those professional boundaries and those physical boundaries as well, and those emotional boundaries, we are going to create a trusting environment. And then finally, empowerment. So this is really where we provide an opportunity for individuals to feel like they are able to advocate for themselves, that they are affirmed. And this should be happening at every contact. So what happens during the visit? How do we put these principles into practice? If you take the next slide, I will talk you through this. So first of all, I'm going to say it again, and might say it again at the end. Trauma is ubiquitous. Sexual violence is ubiquitous for people with intellectual disabilities. You must consider the pervasive nature every single visit, so be aware. Secondly, that means that at each visit, you need to be asking about a trauma history. Make it part of your history. Third is recognizing trauma symptoms. So this is recognizing, we didn't recognize in Troy. We gave him antipsychotics. We said, oh my gosh, this is because of his difficulty with transitions, rather than recognizing that he was being victimized. And what instead, he did not need chemical restraint. What he needed was therapy, understanding. He needed us to ask, to recognize his symptoms, to assess. So how does trauma affect your life functioning? In this case, it was affecting his activities of daily living, his basic daily living skills, and it was affecting his interactions, and as you probably know, when we have these issues of sexual violence, very often there can be internalizing and externalizing behaviors. So just recognize how trauma can affect life functioning experience. And then management. So we want to promote a healing environment. We just talked about how to do that. And then finally, in our treatment plan, we aren't always aware of what resources are available, either online or in the virtual and the local. So your local resources, if you can understand what local resources that are available for positive sexual health, for sexual violence, these will help you across the board for all of your patients, and particularly for those with intellectual and developmental disabilities. There aren't always in every community opportunities, but I think that there are in more and more. So we've talked quite a bit, and yet there is so much more to talk about with regard to sexual violence. And so I would ask that I just gave you the barest introduction to trauma-informed care. In order to do this well, in order to do this on a daily basis, seeking out training on specific treatment approaches for people with intellectual disabilities is needed. And then the second part is to engage with referral resources and to start to understand those community resource organizations, even a couple of them online or in person, so that you have those at your fingertips when these issues come up, because it's inevitable. It's not an if, it's a when. So in this section, we talked a lot about sexual violence, and we talked about a lot of the negative consequences. We'd like to switch gears a little bit, and first of all, talk about the broader picture of self-advocacy and of the experiences of people with intellectual and developmental disabilities, not just around sexual violence, but around sexual health in a positive way, and about how we can promote that. So I want to reintroduce Savvy. It's such a pleasure to get to work with Savvy, and I know that we're going to have a wonderful conversation together. Savvy, I wonder if you can tell us a little bit about yourself and what your role is at Special Olympics before we get to start, and if you can share also some of your recent titles.
Yeah, of course. So hello, everyone. Again, Savannah, Savvy, either way. I am a Special Olympics athlete and also a Special Olympics part of Special Olympics Athlete University, ALPS U, and a health messenger. I really use Special Olympics not just for the sports, but also the community I build, because it's really important to me, and the way I can use it through advocacy methods. I am also, as you stated, some titles. I was the Colorado Miss Amazing Miss, and I was recently crowned the National Miss Amazing Miss 2021, which is really, really exciting. Miss Amazing itself is a pageant system for women and girls like myself with unique abilities. I'm not one who calls them disabilities. But we're not a beauty pageant, although some of us wear beautiful dresses or cowboy boots or a suit, whatever is going to make us feel the most confident and prideful in ourselves. And so we work on advocacy there, and a lot of individuals with Miss Amazing are also in Special Olympics, so a lot of overlap.
Fantastic. Thank you. And I certainly congratulate you on your title as Miss Amazing, and my experience with you is amazing as well. So thank you. Can you tell us a little bit about your experiences with doctors and kind of tell us how you've received the care that you've needed and maybe some times when you haven't?
Yeah, so just maybe two examples I have. A lot of times when I go to the doctor, I go in with my mother because it makes me feel safe and comfortable. And so that's always something that's kind of an accommodation there. I have, I don't know what's wrong with my veins, well, but they always at Children's Hospital have to use what they consider a baby needle. It's the butterfly needle. And I've been told that's the only way to do it. I also am very afraid of needles, and I am just not good with them at all. It becomes a whole issue there. But they were able to find that that is the needle that can work for me. But when going to a regular doctor or even an emergency room, anywhere that's not Children's Hospital, when I say, oh, just a reminder, you have to use a butterfly needle, a baby needle, they're like, no, you're an adult, we don't use those. And I will tell them, hey, Children's Hospital said that's the best option. And they're very negative to understanding that I have the history of understanding what works. Inevitably, then I'm poked like 10 times, trying to realize that that's the way they have to do it. Inevitably, they end up having to use the butterfly needle in the end, usually. And they don't say, oh, I guess you knew. No, it's just, oh, look, we use this. I'm like, it's magic. Another occurrence I've had, which actually I didn't think about recently, but my mother brought it up saying, hey, well, this is something that happens, as you know. I go into mental health facilities because some of my unique abilities do have mental health components. And so I would go into my psychiatrist by myself most of the time because that is supposed to be a safe place. But I went in maybe, I was 15 at the time, and I went in and they weighed me. Of course, I'm on medication that can not be great with weight. And they weighed me, and my psychiatrist was like, wow, you're really getting too big. I think we need to talk about doing some dieting with you. And so that was just a blatant, hey, you're not the right person you need to be. Inevitably, I have never gone into that psychiatrist alone again. I still see the same person, but I go with my mother because I no longer feel comfortable going in by myself because of different things that had happened like that. So those are some instances with doctors that I've had, other than Children's Hospital, which I really love and appreciate because I wouldn't be here without them. So.
Thank you so much, Savvy. If we can shift, how about you tell us a little bit about how you learned about sexual health and who's been important in roles teaching you?
So I would definitely say, first and foremost, my mother, because she is a big advocate of mine and she understands the things I do and how I react to different occurrences. But she has always been open with me, but I never was like, I wasn't active myself. Growing up, I'm still not sexually active, but that's not something I personally want or need, but it's still things that need to be done. I was talking earlier during kind of a practice session and talking about mammograms and pap smears, things that are very, very important. And I know this about health for a woman. I've read about them, I know they're important, but to that fact, I have never actually received one because my doctor doesn't fully understand or want to accommodate in certain ways. And so I don't even know always what the accommodations are, but it's too overwhelming. And so my mother has said, well, if something happens, we'll have to do one. But for this point, it's, it's best because your doctors are not being the right care for you at this point, which I completely agree with and understand. But it is a worrisome factor because they are a very important measure.
Thank you. Yes, I really appreciate that, and particularly, I think recognizing the challenges. I I wonder if you can also comment on people with intellectual disabilities and developmental disabilities, and how they can learn to advocate for themselves, and why is it important for people with intellectual and developmental disabilities to get education on sexual health.
I think it's extremely important because, first of all, knowing what something is can be a great thing. I didn't know what materials might be used or things like that, but those type of things put you in a mindset to know what's coming. I think that's really important for someone with IDD like myself to have the precursors of, okay, this is going to happen, then this, then this. So we're in order and know what's going on. I also just think that when we think of people with IDD, we don't always have to be active. And it might be my choice because I don't have someone that I feel that way about to be active with. But I know many individuals that are friends of mine or co-athletes, things like that, that are active. And that's perfectly normal for their age. But they've had different occurrences where they're not understood. There's so many different things that can happen with someone with IDD on varying levels. For example, I speak very well. That's something I work on a lot. That doesn't mean that when I'm scared or when I'm overwhelmed, I don't speak at all. But that's okay because that's who I am. But I was nonverbal when I was little and I grew to love language and how I can converse those things. But some people will say, oh, well, you don't have these struggles because you can vocalize what's going on. And while I might be able to vocalize in a room like this or a Zoom room, either way, and show who I am, that doesn't mean when I go into a doctor, that changes. I'm very timid in a doctor. I forget all my words. It becomes too much of a heavy situation for me. And so understanding the different levels and how things change for people with IDD day to day is really important.
Thank you. Savvy, this was very, very helpful, and I know we're going to continue to talk about this. I really appreciate your perspective, and Iulia, if I can turn it over to you as well.
Yeah, thank you so much. And thanks so much, Savvy, for sharing your perspectives. I think that last piece leads in really well to the focus for the last part of this session. So in addition to training healthcare providers, adults with intellectual disability really need to be empowered with knowledge about healthy relationships and sexual health. And so to assist towards reaching this end, Special Olympics partnered with the WITH Foundation to develop a training on healthy relationships for people with intellectual disabilities. All right, so to begin this project, we assembled a committee of content area experts, Special Olympics program staff, and Special Olympics athletes. And as a group, we established core competencies and lessons And our athlete self-advocates were really involved in every step of the process. So ultimately, we reached 4 solid lessons that we ended up piloting. These lessons were titled Healthy Relationships in Special Olympics and Beyond, Consent, Communication, and Respect, My Body Belongs to Me, and Pathway to Health. The lessons were designed to inform and empower self-advocates by equipping them with the tools to engage in healthy relationships and to communicate about boundaries and safety. Overall, the lessons sought to positively impact health, knowledge, empowerment, and prevent sexual assault and unhealthy relationships among individuals with ID. So these lessons covered safe and healthy professional relationships, the difference between healthy and unhealthy friendships and professional relationships, that consent means agreeing to a certain activity or behavior, how to communicate consent, that people need to ask and get consent before touching, that one can communicate no to any type of touch or behavior that feels uncomfortable or unsafe, and how to leave a situation that feels unsafe or uncomfortable and then tell someone. Once the curriculum was kind of developed and finalized, it was piloted with 4 Special Olympics sites, Special Olympics Arizona, Colorado, Indiana, and Wisconsin. At each site, the curriculum was delivered by a Special Olympics program staff person, an athlete, and a local expert. Facilitators were trained on how to deliver the curriculum. They were provided with instructor manuals that detailed the content and key messages. And the trainings were delivered via Zoom in 4 45-minute lessons. Each lesson consisted of a PowerPoint presentation that included videos to provide example scenarios and breaks for group discussion. The instructor manuals provided direction on how to discuss each slide, and the program staff person and the athlete facilitator would break up the teaching materials in whatever way worked best for them. The athlete participants also had an athlete manual, which they used to follow along throughout the lesson, and that reiterated the key concepts of the lesson for them. The pilot was conducted this past April and May. Across the 4 sites, a total of 39 athletes completed a pre-survey prior to participating in the class. 35 athletes completed a post-survey following class completion. The 4 athletes who did not complete the post-survey either did not end up taking the class after enrolling, or they only took 1 of the 4 lessons. If an athlete completed between 2 and 4 lessons, we asked them to complete the post-survey. Athletes ranged in age from 19 to 62. The average age was about 36 years. 46% of athletes who participated were female, 72% identified as white, non-Hispanic, 8% identified as Black or African American, and 5% identified as Hispanic. And just over half of the athletes who participated lived with a family member. 22 of the athletes, or roughly 56%, reported having previously learned about healthy relationships. Of the athletes who had reported previously learning about healthy relationships, the majority indicated that they had learned about healthy relationships from their parent or their caregiver. This was followed by from teachers, friends, and then doctors or nurses. The majority said that they talked to these people about healthy relationships only once in a while. Athletes were asked both pre and post class participation to rate their knowledge about healthy relationships or connections to other people. In this figure here, the pre-survey ratings are presented with the red bars. As you can see, prior to class participation, 13% of athletes said they knew nothing about healthy relationships, and 38% said they knew a little. Only 18% of athletes said they knew a lot about healthy relationships. The post-survey ratings are presented with the gray bars. As you can see, following class participation, responses skewed more favorably. After taking the class, 63% of athletes indicated that they knew a lot about healthy relationships. A significant improvement in self-rated healthy relationships knowledge was observed from pre to post class participation. We can see that following the course, athletes reported having more knowledge about healthy relationships, which is very encouraging. We asked athletes to answer 8 questions to test their healthy relationships knowledge, both prior to and following class participation, and these were drawn directly from the lesson materials. These questions included things like, is it okay to yell, kick, or scream to get away from an unsafe situation? Yes or no? Correct answer to a knowledge question was scored as a 1. An incorrect answer was scored as 0. So answers to all 8 of the questions were added to create a total knowledge score. And a score of 8 indicated that the athlete answered all the questions correctly. As you can see in this figure here, at the pre-survey, the average total score was 7.2, and at the post-survey, the average total score was 7.5. So there was no significant difference from pre to post class participation. This is likely because knowledge in these content areas was already relatively high prior to taking the class. There was little room for improvement, and also we had a very small sample. We did, however, see significant improvements in healthy relationship self-efficacy. And this was both at the individual item level and with our self-efficacy total score. Athletes indicated that following class participation, they felt more comfortable talking about relationships with doctors and nurses, as well as with teachers. They also indicated that following the class, they had a better understanding of their relationships, and they felt more prepared to make decisions about their relationships. So these questions were asked on a scale of, related to this statement, how much do you agree from strongly disagree to strongly agree? So our self-efficacy total score had possible values ranging from -14 to 14. A score of -14 would indicate that they strongly disagreed with each statement presented, and a score of 14 would indicate that they strongly agreed with each statement presented. So from pre to post class participation, the average self-efficacy total score significantly increased from 6.5 to 8, indicating greater self-efficacy following the class. And a score of 8 indicates that on average, athletes agreed with all of the statements. Following the class, we also asked for some feedback on how things went from the athletes. 80% of athletes said the class was good. 100% of athletes said that they liked taking the class. 83% of athletes said they would tell their friend to take the class. And 100% of athletes said it was important for people with intellectual disabilities to learn about healthy relationships. When we asked them, why is it important for people with intellectual disabilities to learn about healthy relationships? Responses included things like, because everyone deserves to be in a good relationship. And because we can be taken advantage of, we need to set healthy boundaries. We also asked a couple of questions that were open-ended in nature. So we asked athletes, what was the most important thing that you learned? And athletes said things like, my body belongs to me. I learned what a good relationship is. Knowing the difference between healthy and unhealthy friendships and professional relationships. Ask someone first if it is okay to touch them. Always ask before you give a hug to a coach or another athlete to make sure you have consent. We also asked athletes what they would like to learn more about. And athletes said, how to defend myself. I think we need to know more about personal touch and what is right. I would like to learn about pap smears, and I would like to learn about work relationships because I have problems understanding work relationships because I want to be friends with everyone. And teach more about the body and what happens to people who have sex. So now I'm going to turn it back to Savvy with a couple of questions because she was one of our facilitators in the site in Colorado. So I think it's really important to hear some of her perspectives on what was the experience like leading the class and being part of the project, So first, I love to hear about what made you interested in participating in this pilot project.
So first of all, I was called by the person who runs Alps U in Colorado, given the opportunity to be part of this project, and we discussed what it might mean and who it would be doing, who would we be like teaching this for, how would it work. At first, I was really concerned. I wasn't sure I'd be the right person because I myself didn't have a lot of the knowledge. I was not active. I'm not active, as I said before. So I thought I wouldn't be the right person. But when discussing it, I realized that there were so many different factors involved, from understanding consent to understanding how different friendships can become relationships or vice versa, and how those different things affect individuals. So I decided to do it, and I was so excited I did because I was able to use facilitation skills to be a facilitator, things that I do in school that others might not have had the opportunity to be able to do. Because I'm a CSU student, so a Colorado State University student, and I work in the Center for Public Deliberation and learn a lot about facilitation. But it really was great to be able to take something I'm learning and put it into a live setting.
Yeah, that is great. Can you share a little bit more about your experience doing the teaching and what that was like, and if there was anything that you learned during the process?
Yes, I think a lot of the things that I learned were at the same level as everyone else. We learned about, we had an individual who was in our class setting and ended up saying, hey, the packets aren't accessible. I need Braille. And everyone went, oh, we didn't even think about this. We didn't think about accommodating their needs. And so we ended up, each picture that would come up, we would describe each picture so that individuals would still have the same knowledge that was given to everyone else. And that was something that I think was really unique to our group, but I also think it really helped each other. So.
Yeah, that's a really great example about how we need to be more thoughtful in addressing individual needs in these types of situations. I'll ask you one last question since we're nearing the end of our time, but I'd love to know if there were any kind of key thoughts from your group on what you liked about the training.
I think I learned, and I think a lot of other people learned, that they weren't alone in situations. So understanding different boundaries and examples of that, it really was important to note, because things that I thought other athletes were bringing up and saying stories and giving examples, which I thought was really brave in general to feel so open. But it also helped every other individual in our group understand that this was a really important endeavor and that we all needed it and we all were not alone. So.
Yeah, I think that's really wonderful to hear, and so great that you were able to build that level of trust within your group and all be able to connect on that level. All right. Thank you so much, Savvy, for providing your perspective. It's really valuable and one that we definitely need to hear while entering this discussion. And with that, I will turn it back over to Alicia for one final thought. Oh, I think you're still on mute.
Oh, thank you so much. Thank you all for taking the time on this particular topic to spend with us. We obviously have spent our time, and this is a very important focus for people with intellectual disabilities to be able to become their their own self-advocates. It's a very strong focus for people in healthcare to be able to learn about healthy relationships, which are so important to everyone's life. I will end with this, these calls to action. First, think trauma every time. All care should be trauma-informed care. Second, get educated on healthy relationships and on how to talk to people with intellectual and developmental disabilities about them, and particularly on trauma-informed care. For your own practice, make it a priority, and then change your practice so that it becomes not only a good to have, but a I'm not going to do it any other way. I encourage you to become an inclusive health partner with Special Olympics. As you probably know, we provide a lot of health screenings and health services for people with intellectual and developmental disabilities. And I welcome you. It's easy to just look at specialolympics.org and your local Special Olympics program as well. And then finally, become a champion of self-advocates, of healthy relationships, and of trauma-informed care. I will end with this. So we had a question in the chat about Troy and what happened with Troy. We did give Troy, in the end, the supports that he should have had in the beginning. So he actually did. We finally started looking through a trauma lens. We got him therapy. Actually, working with a trauma therapist who specifically worked with people with intellectual and developmental disabilities, which you can do in the LA area. Maybe you can do online now. It becomes more difficult, but the resources that you can find in your local community are the ones that I would strongly recommend that everybody just call up, find out a little bit about. But even just taking this training means that you have more information and that it's more in the top of mind than it was before. And that maybe the next time you have a patient, you'll think about trauma-informed care, you'll think about sexual health, and you'll think about even healthy relationships, so that all of our athletes can have the same path that Savvy did, and can become their own self-advocates as you have. So I think once we get there, we will be in a much more inclusive world than we are now.
Thank you, Dr. Bazzano, and also Savvy and Dr. Iulia for your awesome presentation. We're getting a lot of responses back here. Savvy, we really appreciate your openness and honesty during this conversation today. And we have some questions that were answered already, but we have some of the questions that I think we can address now. And one of the questions says, will the Special Olympics course eventually be available nationally?
At the moment, it's in pilot phase. As you can imagine, we've only started the work in this area, and we will be working towards the next phases of this. I can't give a date as to when a curriculum might be available, or in what form, because obviously this was originally intended in person. Because of COVID, ended up in a virtual setting, but may end up in an online interactive setting. So it's in process.
And there's also another question about the name of the book that was used and where they could get it.
So I think that might be referring to the manuals for the training. So those were developed in conjunction with a consultant specifically for this project. So they're not more widely available just yet, but hope to continue moving that forward.
And then we did, I think there's, we also, this curriculum was designed as a train the trainers. So we did have trained, and Savvy, you can speak to your experience both in that, but we do include self-advocates as facilitators.
And then there's one last question for Savannah, and it's, have you approached your nurses? Do these issues fall into their scope of practice as well to educate, accommodate? Any perspective on that question, Savi?
So I will say that the healthcare system has faults. It just does. Am on Medicaid, so that can be hard to even get into the doctor's office, let alone make an appointment. My specific doctor, which is a Salute Clinic, so it's a clinic that like is everywhere. You call now and you can't actually call the doctor's office. You get a call center in another country that who then makes your appointment. So while seeing the nurses would be great, I see them like, if I go there every 5 months, maybe I'll see one. So it's not, I don't have a like rapport with them, and they're always new.
Got it. Okay, so I think that's a good time for us to end on a great note. Thank you guys so much once again for this presentation, and I learned so much from all of you guys today.
Yeah, on
Thank
behalf
you.
of AD, I just wanted to thank the panelists for a wonderful presentation, enlightenment. We all need to be advocates for one another and look after one another and be engaged. So thank you for joining us tonight. Thank John Hood for orchestrating this, and this recording will be available on our website later. And I want to thank Cindy Lee for hosting us as our VGR facilitator, and wishing everyone a great night. So thank you all for participating. Again, great presentation, everyone. Savvy, you're a rock star.
Thank you.
Thank you. Good night now.
Thank you all so much.
Thanks
night.
again.
Thank you.
Bye-bye.